Neck manipulation and the VBI test. Let's have a little look at the safety, the evidence, and our responsibility as clinical practitioners, because social media has a lot to answer for. Bad technique, aggressive technique, patients literally being abused for likes and clicks by random strangers. This has created a false dichotomy of what real clinical treatment should be, and it puts the patient and the therapist at risk. Guys, as practitioners of manual therapy, we are entrusted with a profound privilege and an immense responsibility. The cervical spine, which is a delicate and complex structure, demands our utmost care and attention. Its role in human movement and health has made it a focal point of fascination and controversy, especially when it comes to vertebrobasilar insufficiency testing and neck manipulation. So let's have a little look at what the evidence says. Let's look at the risks associated with neck manipulation, and let's also consider ethical, clinical, medico-legal obligations that guide our practice and should guide your practice. So let's consider how we can prioritize patient safety, adopt evidence-based strategies, and ultimately maintain the trust placed in us as healthcare professionals. Now, guys, remember, no single test alone will provide decision-making information. Positional testing is also unlikely to influence decision-making. Remember, the absence of clinical findings does not rule out any underlying pathology of impending cardiovascular issues, okay? Now, the VBI test is actually pretty rubbish. The VBI tests were originally designed to identify insufficiency in the vertebrobasilar arteries by reproducing symptoms such as dizziness, nystagmus, visual disturbances through positioning of the neck. Now, while this approach may seem logical in theory, the evidence paints a starkly different picture, with studies consistently showing that the VBI test lacks sensitivity and specificity. One of the systematic reviews reported a sensitivity of basically 0%, or between 0 and 50%, which means the test fails to detect nearly all true cases of vertebrobasilar insufficiency, and worse still, it can produce false negatives, leading to a scenario where a patient passes the test but still remains at risk of arterial compromise during manipulation. Beyond its diagnostic failure, the test itself can be incredibly provocative. Placing a potentially compromised artery under positional stress risks aggravating or even initiating a potential dissection. Now, this paradox underscores the dangers. So the very act of testing may harm those that we are aiming to protect. So therefore, the VBI test is not only quite ineffective, but it could be potentially harmful. And continuing to use it in clinical practice almost contradicts the principles of evidence-based care and exposes patients to unnecessary risk. The role of clinical case history is probably the most important part of this whole process. It is your diagnostic compass. If the VBI test is obsolete, then how should practitioners assess risk? Well, the answer lies in taking a meticulous and thorough case history. Guys, a well-conducted clinical history can uncover red flags indicating vascular compromise or contraindications for cervical manipulation. If you don't ask, you don't know. You have to ask. Recent head traumas, neck traumas, severe unusual headaches, persistent or unexplained dizziness, neuro symptoms. Is there family history of cardiovascular issues? What's their systemic health like? Obesity, smoking? These signs may point to underlying vascular pathologies that warrant further investigations. Blood pressure testing, things like these simple things that we can add in. But the art of history taking involves not just asking questions, but probing deeply, asking when did the symptoms start? Are they constant? Are they positional? Are they associated symptoms like nausea or limb numbness? And guys, when you're doing your case history, when a red flag or red flags are present, or even if there's reasonable doubt, the safest course of action is just to refer. a neurologist or vascular specialist is going to be much better equipped to assess and manage vascular conditions. They'll have Dopplers, ultrasounds, they'll have imaging. We don't have that in clinic. And this approach not only prioritizes patient safety, but it also demonstrates professionalism, humility, and ethical responsibility. Guys, 80% of your diagnosis is done through a detailed clinical case history, and it is indispensable for identifying vascular risks. It offers a non-invasive, patient-centered alternative to outdated diagnostic tests. Okay? We move on to neck manipulation. Now, this is a skilled intervention and not a reflective act. When used appropriately and skillfully, neck manipulation can be an effective intervention for certain conditions. However, it does carry inherent risks. There is nothing that is risk-free. Adverse effects are rare but occur, such as vertebral artery dissections, strokes, cardiovascular compromise. They can occur anywhere between 1 in 50,000 or 1 in 5 million. It does depend on where you read the research, but the potential severity cannot be understated. Guys, as clinicians, we are obliged to weigh the potential benefits of manipulation against the risks, considering safer and equally effective alternatives, such as things like mobilization, a beautiful low velocity, low amplitude movement, very effective in neck care, soft tissue therapy, dry needling, MET, PNF, exercise therapy. All of these other safer modalities can be very, very helpful and have a minimal amount of risk. These approaches not only mitigate risk, but also empower patients by fostering active participation in their recovery. There is the allure of a quick fix, but this must never outweigh the imperative of ensuring patient safety. Neck manipulation is not a quick fix. Now, we have to also understand that neck manipulation is a skilled medical intervention. It's not a casual act. It should only be performed within a clinical setting under appropriate conditions with the patient's informed consent. There is a significantly worrying trend of people performing manipulations in informal settings. I've seen it on social media, cracking necks in the street, on the aeroplane, in a shopping centre, in a freaking pub. These unregulated environments, it's risky and it's dangerous. Such actions disregard the critical safeguards that protect patients. They don't cover a thorough evaluation of risk factors. There's professional oversight, and also controlled surroundings are designed to respond promptly to complications. That's not going to happen in a shopping centre. Also, manipulating someone's neck without their explicit informed consent is both unethical and unsafe. It exposes them to unnecessary risk and the practitioner to serious legal consequences. Guys, neck manipulation is a specialized intervention that requires judicious application, informed consent, and the safety of a controlled clinical environment. Practitioners must avoid opportunistic manipulations outside of the clinic, as these practices jeopardize patient safety and ultimately massively undermine professional standards. Instead, prioritize safer alternatives and ensure every intervention aligns with evidence-based care. Now, informed consent, communication and transparency. Now, informed consent is the cornerstone of ethical practice, and it requires more than just getting them to sign a piece of paper. It demands a transparent conversation about risks, benefits, and the alternatives to any procedure. So, imagine a patient consents to having their neck cracked after being told they've sort of passed a VBI test, and subsequently an adverse event occurs. The practitioner may face accusations of misleading the patient, as the test could not reliably exclude risk. Instead, informed consent should involve things like explaining the inherent risks of the manipulation, no matter how rare, open and honest communication, offering an alternative to treatment such as mobilization or exercise therapy, and allowing the patient to make an informed decision without undue pressure. Clear and empathetic communication not only protects patients, but also fosters trust and mitigates legal risk. Guys, informed consent must be based on transparency and not on false assurances. Document discussions thoroughly to safeguard both the patient and, more importantly, you. You have to think about medico-legal considerations, and you've got to think about professional standards. So guys, continuing to use a singular test like the VBI and nothing else, despite overwhelming evidence of its ineffectiveness, could be interpreted as negligence. Now, with courts and regulatory bodies, they measure clinical actions against reasonable professional standards. The key practices to align with this standard include staying current, regular reviewing of the latest evidence and positional guidelines, documentation, maintaining detailed records of patients' history, clinical reasoning, and the consent process, continued education and training, ongoing education to refine skills and stay informed about safer alternatives. Practicing within the bounds of evidence-based care not only protects patients, but ensures the integrity of the profession. It's really important we adhere to evidence-based standards. It's both a clinical and legal imperative for us. Regular training and meticulous documentation really are essential safeguards. Now, a call to evidence-based practice ultimately, and our mission as clinicians is to heal without harm. Now, this requires embracing modern thought process, embracing new research, embracing better standards of care, prioritizing patient safety and minimizing risk and involving your knowledge. So next time someone presents to you with neck pain, ask yourself the following questions before you put your hands on. Have I taken a thorough case history to rule out red flags? Am I relying on flawed or outdated methods? Have I explored safer alternatives? Have I communicated the risks and the options transparently enough to the patient? Are they informed? Are they aware? Do we have shared decision making? This represents a commitment to ethical, responsible and effective care. And by prioritising these principles, we do honour the trust the patients place in us and uphold the highest standards of our profession. I know this has been a very long rant, but guys, neck manipulation should not be used in a cavalier, nonchalant manner. Cracking the necks of people in the pub, in the street, outside of the clinic is unprofessional, unethical, and dangerous. Cracking people's necks without doing a thorough case history is unethical. It's unsafe and it is dangerous. Not doing a thorough case history, regardless of the presentation, is not ethical and it's not safe. If in doubt, refer. If you're not sure, refer. Write stuff down. Do a thorough case history before you consider neck manipulation. Ultimately, no one will ever criticise you for being cautious, but they will criticise you for being cavalier. If you're not doing a thorough case history, if you've got a tiny reduced treatment time and it's literally in, crack, out, in, crack, out, in, crack, out, that is not therapy. That is, in my opinion, just taking the money. And the patient would probably be better off taking an ibuprofen rather than spending the money on a treatment that is not ethical or not evidence-based. So, clinical thought process. Is it appropriate? Have I done a good case history? Are there alternatives? Have I documented everything? Have I asked all the right questions? Have I done all the relevant things to keep myself safe and keep the patient safe? And if you have, and you want to crack the neck, crack on. But if you haven't, stop, think, and reassess.